Today on Town Hall.
It was often less of a money issue than it was how much change could be absorbed. What I had to decide pretty early on was that I had to be flexible and really give on what was going to be day one versus day two, and let that really be a collaborative process.
My name is Bill Russell. I'm a former CIO for a 16-hospital system and creator of This Week Health, where we are dedicated to transforming healthcare one connection at a time. Our Town Hall show is designed to bring insights from practitioners and leaders on the front lines of healthcare. All right, let's jump right into today's episode.
I'm Sue Schade, principal at StarBridge Advisors and one of the hosts for the Town Hall show at This Week Health. Today, my guest is Jeremy Meller, Chief Information Officer at Children's Healthcare Atlanta. Jeremy's been in this role since 2020 and with children since 2012. I've known Jeremy for several years now, and I'm really looking forward to talking with him today to hear what he and his team at Children's are focusing on. So welcome, Jeremy.
Thank you, Sue, so much for having me. It's great to be here to talk about our new hospital and our experience.
Great. We will definitely get into that. Let's start by having you briefly introduce yourself and tell us about Children's Healthcare of Atlanta.
You bet. Like you mentioned, I've been with children for 12 years. I've been the CIO since 2020, right when the pandemic started. Children's has 3 hospitals, one of them in downtown central Atlanta near Grady Hospital, which many people know. And then we have 2 other hospitals. One of those was on the Emory campus, and that one has closed as we've opened up our new Arthur M. Blank Hospital. Total of going on around roughly 800 beds across the hospitals. We have 19 other locations with things like urgent cares and surgery centers, et cetera. About 14,000 or more employees, and really one of the busiest, but most measures among the very busiest of pediatric hospitals in the country, freestanding anyway.
I know you've had a lot going on. You just mentioned the Arthur M. Blank Hospital. I know you're going to tell us more about that new state-of-the-art facility. And I know that you presented at the Chime Fall Forum a session titled Building a Smart Hospital from the Ground Up. For those of us who didn't get to hear that presentation or weren't there, can you tell us about it in terms of the planning process, some of the new technologies that were deployed, and get into the logistics of moving day? So I know those are 3 kind of big questions for you to start with.
Yeah, absolutely. A project of this scale, and this is a giant hospital. This hospital is the largest hospital facility, kind of initial build of anything in the history of Georgia. About 2 million square feet. It's the same size, roughly, as Mercedes-Benz Stadium in the major new football and sporting arena in town. The first 4 floors are the same size as the facility we shut down. And we obviously, when we were thinking about this, we were thinking first about location, then we were buying property around our office park, and then we had a whole master facility plan. And all of that takes so long. And from an IT perspective, you're involved pretty early on as you're thinking about the services you're going to be providing, et cetera. But then you're also thinking about what are the technologies that you have to accommodate. And in 2017, 2018, when we were doing a little bit more detailed planning here, we were like seriously thinking we were going to have to accommodate self-driving cars coming up all day, every day, drones flying everywhere. And it's just interesting, yet we didn't really account for things like generative AI, because that wasn't really on anybody's roadmap in the same way. So I think you don't know where history is going to go, but we did do some things like, for example, we had a giant warehouse, 100,000 square foot warehouse. And in this warehouse, we built this cardboard city, which were like layouts of the units and different types of rooms and services and the hospital. And we had 1,000 people go through there and test out different workflow scenarios, which led to everything to, okay, where are the outlets placed in the right place? Is this door going to inhibit? To do a code in here, we're going to need all these people. Do we even have enough room for it? And that sort of thing. But one of the things it did is it also really opened my eyes to the fact that moving around a facility of this size was just going to take so much more time. That became one of our really guiding points here, is what could we do from a technology perspective to save time and steps, both physical steps and process steps. The second was that we said, we are in just these growing trends of complexity of patients. More and more, our inpatient census has grown. It probably hasn't grown at the same rate as the population has grown, right? Even though the birth rate and counting the birth rate and everything else. And that's because, as we know, that more patients with more chronic disease that are stable can be taken care of at home, which leaves you have this increasing percentage of your population, especially in pediatrics, that are really acute, really complex, and that's only increasing. So we knew that we were going to have to do whatever we could from a technology perspective to help clinicians make better decisions, make more informed decisions, just handle the mental load of all of the tasks, reduce those tasks so they can spend more time on quality decision making. And then finally, of course, with the pandemic, that was the latest thing with just the expectations related to patient experience, family experience, consumerism. And the expectation is that I be kept informed and that I be allowed to do it myself if I can, whenever possible. So those were the three big guiding principles: saving time, supporting better decisions, and enhancing the patient experience. And then we tried to figure out how do we build the technology and prioritize those things that would have a meaningful impact.
Love those principles. Can you comment on some of the technology that you did deploy in support of them?
There's three levels. We started, if you kind of work backwards, we said, okay, here are our big three milestones. Then you say, okay, what are the actually applications and features and things that you would want? And then you say, what are the foundational things that we really need to install from the ground up to make this happen? For example, one way to save steps is to allow our clinicians to be more mobile. I've got a nurse who's in the middle of a complex medication administration, which we know is an inherently risky action, but necessary, right? And we also know that 90+% of nurse alarms are false alarms. If a nurse is getting an alarm and is in the middle of something and has to stop that action, go check the alarm, come back, restart the action, that's just causing potential for errors. If instead the nurse can get an alert, they can open it up, they can see that clearly a lead is disconnected, then they have more information that helps them prioritize what they do, saving steps, saving time, hopefully improving quality. In order to do that, then we work back to what are the foundational technologies. Certainly, we need a robust, secure network. We need complete device integration. So we have thousands of devices that we said, look, we have been messing around with this for years and years. We've said, look, we've just got to do it. And nothing comes into the hospital that is a medical device that can be integrated that isn't integrated. It's all going to be integrated. And we're going to have all of the data so that we can use the data for these purposes. We're going to treat these medical devices instead of standalone operational technology. We're going to treat them like information technology because that's what they are as well. So that was a big thing. The next was really location awareness related to our staff. That was a big change management issue, as you might think.
Oh, yeah. That's one that could meet with a lot of resistance.
Potentially, yeah. But we were finding 90+% compliance with wearing the location badges. And we think part of it is really the fact that one of the key features of that is staff duress. If you push the button on it several times, security will know exactly where you're at, and they can come find you and help you quicker and faster. And I think just in the world we live in, that's just become an increasingly large priority. In fact, when we deployed it there, we started getting complaints from another campus where they were like, when do we get ours? Because we want to have it too.
Yep.
But in addition to that, we built features in that were really important and helpful for our teams and provided some great patient experience. So when you enter a room, there is a door board on the outside that, of course, has your precautions, and it's an electronic screen, right? But it has a halo light. And if you are a nurse, it'll have a one color. If you're a doctor, it'll have a different color. If you're a respiratory therapist, it has a different color. And then it'll actually alternate colors if there's multiple people in the room. So when you think about it, then you have somebody who's, okay, I know the doctor's on the floor, and quickly glance up and down the hallway and say, oh, the doctor's 3 doors down. And that's another thing that saves some time. Then when you get in the room, there are 3 screens. There's your typical patient engagement screen that may have your educational videos, allow you to watch movies, Netflix, whatever else. There's a duplicate screen like that for the parent, a little bit smaller, on the back half of the room where the parents can watch their own content. But then there's also a vertical screen. And on that vertical screen, we have Epic Monitor running. So in the normal mode it runs in, it's just like an electronic nurse whiteboard. And so it gives you information about your care team, what your schedule may be for the day, et cetera. And there's also a writing pad where the parent or family member can write. But if I walk in with one of those location badges, then I can touch the board and it'll switch to showing me vitals. It'll allow me to show radiology exams. It'll allow a whole bunch of functions and there's no additional authentication required because we know who you are. You just enter the room. When we build in the features like that, then we also find that the compliance helps and we get wins in multiple directions. I would say, at least from the in-room perspective, then the other real big foundational thing we invested in was cameras. We've got over 2,000 cameras overall in the hospital, but then we have a really high quality pan tilt zoom camera in the room. And our initial use cases were to use that for interpretive services. You can get an interpreter on really quick, which is nice. Family conference. So if you've got grandma or grandpa in Colorado that wants to call in, and it's such, you wouldn't think it would matter if I can just FaceTime, but it is such a high quality camera and picture and experience. There's a microphone right above the bed. It gives it a whole different kind of thing. And then our physicians can be anywhere. They can be in our medical office building across town, and right from Epic, they can click on the patient and they can dial into the room. If they've got a question or somebody's got a question about the patient, they can boom, be right there. And so that adds this whole virtual aspect of it that just has provided so many benefits so far, and everyone's really excited about. I could certainly talk about the robot fleet of 90 robots.
Let's hear about it. But just to go back to your original principles, so what you were just describing in terms of what's in the room and the cameras, et cetera. So that sounds like it goes pretty far in terms of patient and family experience.
I think so. I think especially collectively, all of these things that we are doing, we have that. We have a new mobile app that's got some generative AI capabilities to it as well. We've got it all integrated in with our hospital schedule and all the things that may be going on, or when the therapy dogs are going to be coming around or whatever it is. It's all connected, whether it be there on the information board on any of the newer screens you may have.
All right, great. You talked about the robots. Tell us more. 90 robots, and what's their role?
There's 3 different kinds of robots. 2 of the 3 kinds go with the front hallway. One is like a secure cabinet with a fingerprint reader, and you can deliver medications to units, etc. And so if I've ordered something, I will get a alert on my Volt, my mobile smartphone, saying that it has arrived. And so I can walk to the nurse's station. When I put my fingerprint on it, only the part of the cabinet meant for me opens up, so I can't take anybody else's meds. I can only take my own, of course, or supplies or whatever it is. So that's one major use case. They deliver meals. That's a little bit of a different kind of robot that delivers the meals. They'll deliver other kinds of supplies. We've got larger ones that go with the back hallway. They'll move trash around, etc. We've only been in the facility 2 months. It's a neat learning experience. I wouldn't say that it's easy, because you have to really adapt how the humans can get in the way of the robots just as easy as the robots can get in the way of the humans, right? So we're all learning how to adapt and work to this.
I was tripped over one in the grocery store, I will tell you.
Well, yeah, and they'll sometimes get stuck with each other, and very politely, each of them asking each other to move, and they'll eventually work it out. It's very interesting. It's like a Roomba. They'll shimmy around and eventually move on, but it may take 5 minutes for that to happen or more. And so we're working hard on figuring out how to plan the routing and times of day, so we're not sending an army of robots up to a unit that might be doing rounds right now and causing chaos or whatever else. But really, it's a lot of fun, and there's a lot of potential there. And one key thing about this, though, is I think a new facility makes it feasible, because when you look at how much room robots take, the robots have got to charge. There's maintenance rooms. There's rooms to clean them. There are cart washers, where it's like the carts that they move around, they go through almost like a car wash kind of situation. And then on every floor, you have depots. And these are rooms. And by the way, there's 9 elevators just for robots.
Dedicated to robots only.
The robots call the elevators themselves. They get on the elevators. They go where they're going to go. They get off. And then there's these depot rooms where they drop and pick up things. And so you have to have space for all that. Now, when you're talking about a 2 million square foot facility, it's not as expensive as you would think to add that space. When you're talking about a constrained existing facility, of course, it could be nearly impossible. Yeah. So that's where it was a real opportunity that's probably hard for people to replicate, at least at that kind of scale.
There's actually 2 questions as follow-up to everything that you're explaining. One of them is your other campuses, your other hospitals, older facilities. Are you planning to retrofit, so to speak, and deploy any of the new state-of-the-art technologies you put into the Arthur M. Blank Hospital into those older facilities? Talk a little bit about that.
Absolutely. We are not going to differentiate care between different facilities. And in fact, some of the things that we went live with at the newest hospital, we even piloted at our existing hospitals. And so where do you go from here? And that is one of the the top things we're working on right now is planning and scoping out our new renovations to some of our other sites as well, and what we're going to prioritize and what we're going to be able to do there. There'll be some things, like I just mentioned, the robots, that just aren't going to probably be feasible, right? Just the physical layout just won't make it possible. But there are other things that are quickly becoming the standard of care.
Yeah. Now, when I was the CIO at Brigham and Women's Hospital in 2008, we built a new cardiovascular facility, hospital, inpatient, outpatient surgery procedure. And we had the long-term planning, what technology we were going to be putting in, try to think ahead 30 years if you can. But there was that have not. We're going to put stuff in this new hospital and then across the street over the walkway bridge into the old tower built in, I think, the 70s or 80s, that we can't possibly deploy some of the same things.
Yeah, it's one of the biggest issues.
Yeah. Yeah.
Sure.
So another follow-up I wanted to ask you about is change management. With all this new technology, staff had to adapt to the new building, the new flows, and a lot of new technology. How did you manage all that?
Oh, yeah. Great question. Because we hired many hundreds of additional people just because of the size of the facility, the scope of our services, the fact that you're adding more than 100 additional beds just to start. And the whole thing is built around a facility at its maximum size, of course. You build the capacity to where you're probably going to expand to. There was a lot of focus on what was going to be day one versus day two, things that we were going to adopt. And probably the biggest, it was often less of a money issue than it was how much change could be absorbed, because just a recognition that the clinical staff was just the mere fact that it's a new facility, and you wouldn't believe the number of processes that change just because of things like layout and how communication is going to happen now and setups of departments and things that end up changing. So there was so much to absorb there. What I had to decide pretty early on was that I had to be flexible and really give on what was going to be day one versus day two, and let that really be a collaborative process. There are things, for example, I described with our video cameras, there are so many ideas. When we did the ideation sessions, we had pages of ideas of things we could do. And we said, you know what, we will get to those, but we're just going to focus on interpreters and remote family visits. That's what we're going to start. We will reevaluate within the months after we open and what we want to do and go from there. And so that really helped the operational folks who just felt the weight and the burden of this transition felt, okay, I can live with that. Then they became really supportive of a lot of things that we collectively wanted to do. But we had to work through. The other big thing was the change management with the location tracking. And there were people who were afraid we were going to track how much time they were in the bathroom. And we had to convince them that we're not interested in that. We're not going to store that kind of information. We're not going to have it available. The other thing was, by default, the system would allow you to find where any other staff member was in the hospital. And we just decided, you know what, that just seems creepy, honestly. It seemed like there was no really good enough use case for that to enable that. So we turned that off. That's just not something you can do. Yeah. You can see, for example, if a physician had been in the room and that's sustained for a period of time, a couple of days. And that's really helpful. For example, if you have a hospitalist who wants to know if the specialist has been in to see the patient or not. Okay. That is going to really affect everything they do. And so to get to that information easy is part of the record. So I would say we classified a lot of our changes and transformation by the amount of impact it was going to cause and what we were deciding, because that you just have to be realistic.
Yeah, it's interesting to hear you talk about that, because I think when those systems were first available, there was a lot of pushback and concern. So I'm guessing that the vendors have evolved in terms of the granularity of features that you can enable or disable. So that sounds like a real plus in terms of what you've been able to do with it.
I think they've evolved, but I think that we have really pushed, especially these vendors who maybe aren't inherently software systems, that are maybe work in this world of, because we had about 210 systems that we needed to do integration work, modify the system, change the system in some way. We had 60 systems that we actually added to our portfolio with this new hospital. 60. And it was, and many 60. Many of them were actually existing facility systems that now were intelligent, that were internet connected, that were IoT, that were monitored or otherwise smart enabled. But what we find is that many of these vendors, and I'll put, for example, the location tracking in the category of, there just wasn't a whole lot of thought around high availability and monitoring. And we demand that any of our critical systems, we know instantaneously if they're not working properly. Right. They're being monitored continuously, ongoing. And so that's something we've really had to push really most of those vendors on in pretty big ways, because they just weren't really used to operating that way. And when you're thinking about staff duress, all of a sudden that becomes a life safety system, right? Whereas in the past, it's a helpful system to help me find where that ventilator is.
Yeah. So I know we've covered a lot already, but I do want to ask you about any key challenges that you faced and any key lessons learned that you would be willing to share with colleagues who might be going through a similar kinds of major construction, new hospital, new facility project.
We actually staffed a 3-week IT command center. So we were about round the clock for 3 weeks. We ended up shutting it down after about a week and a half, which often happens with command centers. You
plan for the worst, right?
You plan for the worst, but we were expecting 2 to 3 times normal call volume, and we had 20% additional call volume, and that was it.
Wow.
And what I attribute that to is, one, we got started really early. We were taking this seriously 3-4 years out, and we put the resources on it that we needed to. We really cleared the decks as much as we could for IT. We put 183,000 IT hours into the work, and we had some contract project managers, but we didn't have contract staff help us with this. So we really built it from the ground up as much as possible internally, and we cleared as many priorities as we could in order to do that. And then we tested like you wouldn't believe. In fact, there were tests driven by transition teams, and we said, no, those are good, but we're going to build upon them, and we're going to do additional IT tests on top of them. We're going to do additional IT scenarios. We're going to do additional walkthroughs and dress rehearsals, and we did them over and over and over again. And every single time we fleshed out tons of new issues that we just didn't realize that we had. And so that, of course, at the end of the day, is you got to start early. Don't think too small. I would think big in terms of how you want to approach it, and then allow plenty of time for testing.
Great. So I also wanted to ask you about any other current priorities. Now you have the new hospital behind you. You've got a lot of technology deployed. It sounds like you're deploying some of it now in your other facilities. Any other current priorities that you're working on you want to share?
Like I said, we put a lot of things on the back burner. So there's plenty of work that's really queued up and tons of demand. But I think the other thing is, as this was going on, we had some really rough stuff with Change Healthcare, Lurie, others that really has opened, I think, folks' eyes to the fact that a big scale ransomware event like what we've seen, and 150 hospitals this year, 150 last year, at least that we know publicly, there are probably more smaller scale type incidents, have been taken down for weeks to months with ransomware. And is there any natural disaster that has that kind of likelihood and impact even? It's pretty hard to imagine in terms of that. If there were 150 hospitals taken out by tornadoes last year, you would probably know it.
Yeah.
So I think the organization has really seen how we just have got to be better prepared from a business continuity perspective. So that's one of our biggest organizational initiatives, is actually getting really serious about business continuity and everything that we can do to give our organization, our leaders, confidence that we have hardwired resiliency. Certainly access, digital patient experience, that's huge as well. A lot, just a whole host of quality, capacity, outpatient, surgical, and other specialty strategies. But in terms of where technology is probably going to have to work the hardest, it's around stability of the new hospital, really making everything hum the way we want it to, our business continuity, our access, digital patient experience, and other site improvements.
Okay, great. Is there any technology that you're keeping your eye on, looking out 5 years ahead at this point, considering everything that you have deployed in this new facility?
So I think it's always a bit of a, like I was talking about the fact that we were sure that we were going to have drones every 5 minutes, and we were going to have self-driving cars. And self-driving cars is certainly happening, but not at the speed and pace we thought. I think all of us have to decide how hard are the bets are we going to place on what we think is going to happen versus what's a little bit more in the immediate. But I'm sure all of us are just looking at the role that AI is going to play, really try to understand everything from self-directed automation to predictive diagnostics, content generation, and everyone's seeing such great uplift on things like ambient documentation, et cetera. So that's just exciting to watch. And we try to have a place in all of those things. We've got a great health informatics research core as well, where we can channel a lot of that work and try out things. We decided to make an investment in allowing ourselves to be able to try things like that and stay as close to where things are going as possible. But then I think a lot of folks are curious about what kind of regulatory changes may be related to the new administration coming in. You think about last time around, and there were things like the Cures Act and information blocking, et cetera. Now, some of those things didn't end up being quite as impactful as a lot of people had feared. I think we're going to have to wait and see, right? That's a lot of the stuff I think that we rely on you and your old team to help keep us informed as well.
Hopefully we can do that, but none of us have that crystal ball. I know we're running out of time here. Is there anything else you want to highlight before we close?
I think that we covered everything. It has been a great opportunity to open a new facility, build it from the ground up. It opens a lot of doors to a lot of things you otherwise probably just wouldn't be on the table. So that's been absolutely wonderful to be a part of, and we've been so happy to be able to share this as well.
Congratulations on your successes. That's wonderful. Thank you for everything and all your insights today. It's been a pleasure.
Been a great conversation, Sue. Thank you.
Thanks for listening to this week's Town Hall. A big thanks to our hosts and content creators. We really couldn't do it without them. We hope that you're going to share this podcast with a peer or a friend. It's a great chance to discuss and even establish a mentoring relationship along the way. One way you can support the show is to subscribe and leave us a rating. That would be really appreciated. Thanks for listening. That's all for now.